So in today's talk, we are going to look at this. I'll take you back to the basics. We'll talk first about the definitions of an epidemiology of malnutrition. There are lots of definitions. Try to isolate a few that may be more easy to understand. And we'll talk about classification of, and we'll talk about the gross monitoring using Z-score charts. So I chose Z-score charts because those are the ones that they are put on the children's book, the Road to Health booklets. So that will take you to how to interpret those, so that when those kids come to your room, you'll be able to interpret and understand what it means. And we'll talk about classification of malnutrition, the causes of malnutrition, and some changes, physiological changes that may happen in children with malnutrition. Look at the complications and how to identify the danger signs and how to manage those children with malnutrition. So we will be dealing mainly with those. Malnutrition is a big topic, so we try to summarize, looking at the important aspects that we may want you to know. So we hope by the end of this session, you'll be able to plot or interpret WHO Z-score growth charts and able to classify malnutrition using those Z-score charts and be able to identify and correctly treat children with malnutrition and know the 10 steps approach in the management of malnutrition, which we expect everyone to be able to know this by the end of the presentation. So what is malnutrition? And before we go to definition, just to highlight, malnutrition remains a global health concern, and they contribute significantly to the childhood mortality. So about 45% of all deaths among children under 5 years of age are somehow linked to the undernutrition, mostly in the low and the middle income country, where our country also fall on that category. So with the implementation of good implementation of managing the malnutrition using those WHO guidelines, we are able to reduce fatalities due to severe acute malnutrition. So currently, this was from the WHO. It shows that the currently 149 million children under 5 are affected by stunting. Stunting is, as explained, is meaning too short for their age. And about 45 million children under 5 are affected by wasting, which they are too thin for their height when we use the weight for height cross charts, which we will show you. And also 39 million children under 5 are affected by overweight. So we can see that this is really a serious problem. And also that overweight is also malnutrition. Malnutrition doesn't mean those who are underweight. Those obese are also having malnutrition. So, and of all those ones, most children are found to be living in Africa and Asia, those who are affected by malnutrition. So in Africa as a whole, about 41% of children, they are affected by stunting. And then also 27% are affected by wasting. It means they are very thin for their age, they are very thin. And then 27% again in Africa, they are overweight. So you can see it's a serious problem which we need to deal with as early as now. And most of these problems, especially looking at the overweight, we now, the new generation parents are main contributors, because we are the one who are feeding these kids with all the junk food. We are keeping our children with less activity. The activity they have is to play game on their phones, is sit in front of the TV day long with less activity. Hence, we'll find now we are finding lots of children with overweight and obesity. So looking at some definition of malnutrition, I'll take some definition. So there's a lack of uniform definitions. So child malnutrition may be defined as a pathological state resulting from inadequate nutrition, including undernutrition, which is, we talk about protein energy malnutrition, which most of people, when they think malnutrition, that's what they think, that's all malnutrition. So this one is mainly due to insufficient intake of energy and other nutrients. The overnutrition, we talk about overweight and obesity, due to excessive consumption of energy and other nutrients. Is also malnutrition. And it can also be some deficiency disease. This will be due to insufficient intake of one or more specific nutrients, such as vitamins and minerals. And from this journal, they also the same definition, which is more which I think I like this one, mainly looking at the undernutrition. This one is the imbalance between nutrients requirements and the intake that result in cumulative deficit of energy, protein, and or micronutrients that may negatively affect growth, develop, and other relevant outcomes. So those are some definitions. So before we go details on what is malnutrition, how malnutrition manifests, how do we see it, I'll take you through the growth charts, which I hope people will be able to concentrate on this one, because this, if you understand this, you'll be able to identify malnutrition early. For the sisters or nurses working at the clinic, as they are our first line of defense, because most children, they start at the clinic before they go to the hospital. They should be able to identify malnutrition looking at those growth charts as at the beginning of that, and be able to treat before it reached to go to the severe acute malnutrition. The same applies to our general practitioners, because our patients trust them. So if they're able to look at these books and interpret and advise accordingly, patients are able to trust them and able to correct and fix the malnutrition as early before they get complications. So to some people, this may not be new. They may know about, they've seen this. There's those what we call bell curve. So that's just illustrate the principles of Z-score. That's how the Z-score are derived from. And this one is putting this, comparing with the percentile. Remember before we were using the percentile growth chart. So with this one, I just want to show what it means, how those growth charts, these charts came about. So if you are looking at this percent, the Z-score is talk about 0, 1, 2, 3, -1, -2, -3. And the percentile, they talk about the third percentile, 10th percentile, 6th percentile, 50th percentile, and 97th percentile. So 0 standard deviation is this equivalent to the 50 percentile. Is this one, the one at the apex of the curve? Is this, as I said, the same as a 50th percentile? So that is a mean at the peak there. So when we talk about the -1 and the +1, this one -1 and +1, if we were to compare that with the percentile, so the +1 is the equivalent to about 85th percentile, and then -1 is almost around 15th percentile. And we go to -2. -2 is roughly equivalent to the 3rd percentile, those who are using the percentile charts. And then +1 equivalent to the 97th percentile. So when we go the -3, the -3, because if you are using percentile, so it does not really include the -3 and +3. So that's the one we're using now. In the olden one, the percentile, which are still used by other centers and other countries. See, this how they look alike. They how to compare the percentile and the Z-score charts. So before I even show you the charts, the important thing to be able to interpret the Z-score accurately and correctly, you should have done the right measurement. You should have measured the chart width, the chart height accurately. Because if you have a wrong measurement, you are going to interpret incorrectly. So how to measure the height? Let's start with the how do we measure the height in children? So there are two ways of measuring the height. So I'll start with this one, they call it length board or infatometer. So this is the one you can use for measuring the length in smaller children. So with this one, you need at least two people should be able to be able to do correctly. One would be able to position the child and keep the head at the edge of the board, and then the one in the leg and able to push that board to touch the feet. And just measure it have the centimeters, and it will be able to get what is the length of that chart. And you can in this way you get an accurate length. This works much better than when you are just using using that chart. So I prefer to use this one if you have. It works much better. And for those who can stand, using the call it height board or stadiometer, he should be able to stand straight with the legs together, and with keep also the feet together and stand straight. The heels should touch the wall, and also the bottom should also touch the wall, and the head standing straight and touch the wall. And they look up there, you can pull the measuring guide, put it on top of the head, and there you should be able to have what is the length of this chart. So using these two ways of measuring height, it works better than using the meter without guide. So also for how to measure the weight. The weight can measure using the infant scale, or they can also stand when you are using the bathroom scale. And for those who have this kind of scales, with this one, you can put to measure the weight on it, or also on the same, you can even also measure the height, because it can also work the same as the infatometer. So those who have this kind of scale. So if you are able to measure the height and weight correctly, you should be able to interpret correctly those charts. We know our interpretation will be more accurate and relevant. So try to use those for those who have is better than using the measuring tape. So I'll start with the MUAC, what we call MUAC. So MUAC, what it means is a mid-upper arm circumference, which is a small tape. Some of the small tapes that are for measuring mid-upper arm circumference, they are color-coded. The color-coded, which it would make much easy to use even for those who are not really, even the grandparents, our grandmothers can be able to use it. You don't need to be a doctor or a nurse to be able to measure this. So they teach them using the color coded. So advise them if they put this on the mid upper arm, If the color there is green, which means that child is not malnourished, growing well, but you measured come to red, just this child is having severe acute malnutrition, they must quickly take the child to the clinic or to the hospital for medical attention. If it's in the yellow, it just say we are at the risk of developing malnutrition. They must also go to the clinic, and then they can assist with some nutritional advice and counseling. So this is being used in some country, like in, I think, Tanzania. They were giving this to everyone so that they can use at home to monitor their children. So in case they fall under this, they are quick to go to the clinic. So how do we say whether it's normal or not? First, you must know that this one can only be used with children between 6 months and 5 years old. So if you put the measurement is less than 12.5, is doing this child is having acute malnutrition, they should go to the health facilities for assistance. So these are the gross charts that you'll find on the Road to Health booklet. So I'm just going to assist you on how to interpret those. I will put some interpret so you can be able to understand when you are looking at those booklets. So then the green one in the green 0 is the mean. It just means that most children of the age that we'll be looking at, their weight will be falling around that line. So what is normal? This applies to all the charts that I will show after this one, of the gross chart that I'll show after this one. If you plot the chart and the weight is between these two red, that is between -2 and the +2 standard deviation of Z-score, that is normal. This applies to all the charts. Looking for the height, the weight for height is normal. And if plotted between these two red is normal. But you plot, even the chart's weight is falling between this -2 and -3. This chart is underweight. If you plot below -3 standard deviation Z-score, this chart is severely underweight, and most of these, they are likely to be sick. So you plot the chart in coming to a clinic, you find they'll be plotting on here. You must quickly refer that child to the hospital to be assessed. So also when they come to you, you plot, when you plot them, you find out they fall above +2, between +2 and +3. So we know this one is overweight, and it's plot above +3 is an obesity. Everything you plot above here is obesity. For example, if you have a 1-year-old child with a weight of 14 kilograms, you're gonna plot around here. So that child is obese. He should be referred for dietitian for counseling and with dietary advice. And when you're looking at the length of this child, we have said that 45% of all children, they are stunted. Stunting, they looked at this length for each child. So if you plot the child's height or length, you find that it's fall between this -2 and -3. Then look at the blue arrow, blue star. So if you plot there, this child is stunted, and it's plot between this -2 and then +2 in between there. That's a normal height for age. For those who are growing in a faster rate, their height may be around 70 centimeters by the time they are 1 year old. Others will be almost around 80. That is normal. So they may not be the same. As long as it's fall between these two lines, is still normal. But you plot them, they fall below -3, so this child is severely stunted. And of note here, if you have a child who's severely stunted or any stunting, this child is just telling you about this chronicity. This child has been chronically ill. So that, because if it's an acutely ill, usually the length is not, they don't lose their height, they maintain their height, remain normal, they don't become short. So if they find them, they are very stunted, it tells you this child is clinically ill, is preserved in an acute illness. So when we measure, we have looked at the weight for age, we have looked at the height for age. Now we look at combining the weight and the height together. When you combine looking at the weight and height, the relationship between the weight and the height. So if you do that, let's take for example, you have a child with a length of or length of 90 centimeter, and then the weight, when you check the child weight is around 8 kilogram. If you check that child is gonna fall around between -2 and -3. So it means that child is wasted. If it fall below than the length of 90 and it's weighing around 8 centimeters, it's gonna come around there. So this child is severely wasted. So this is how you interpret the growth chart. Those are the first that I mentioned. They are also very much important for all the younger one. We need to monitor those. And then also the same if they are plotting above +2 or between +2 and +3 standard deviation, they are overweight, and above they are obese. And for the bigger kids, those who are older than 5 years old, you can measure the body mass index. So, and we calculate that, and then you can also plot them in the charts. And just to remind you, the normal body mass index should be between 18.5 and 25. That's normal. If you calculate and they are falling less than 18.5, those ones they are underweight. So just have to also know the body mass index. I think this even the adult, they do use a body mass index. Looking at you can also look at the height and the weight relationship. And in summary of the growth chart, which if you were to forget all others, just try to remember this one because it summarizes what we were just discussing on those charts. We spoke about in summary, when looking at the length of the height, if it fall below -2 standard deviation, that child is stunted. If it fall below -3, is severely stunted. We're looking at the weight for age. If they are falling below -2, if they are underweight, below -3, they are severely underweight. And we look about with the weight and the height together. If they are below -2, they are wasted. Below -3, they are severely wasted. So this slide summarizes those cross charts. And this one, I just put it just to remind you, every time when the child comes to your rooms, to the clinics, or to their surgeries at the hospital, yeah, just get a habit of looking at their books, because there's a lot of information that you can pick up from this book. You can do to see all about their nutritional status, check their immunization status, look at the growth chart. You can see if the child are been growing well or not. And we are able to see where the problem started. And when we look, most of the time, our children start to lose weight after 6 months. The first 6 months, they usually have a normal weight. But after 6 months, that's where we start seeing the drop in their weight. The reason for that most of them, they are weaned off the breastfeeding at 6 months, and they are weaned to a wrong diet. And that's when they start losing weight. Some they are just weaned off from breast milk to a rooibos tea and marilla salt porridge, which some people they are using that as a diet, which is a wrong diet for the kids because they don't grow with that. And there was no way where I ever said the tea is a staple food for the children. So you just get a bit of looking at these books. These are the old books, which they were for girls and the boys. The new books, these are new books. which both boys and girls are using. They have the growth charts for both girls and the boys. So just get the habit of looking at these books. You will save a lot of these kids because you'll be able to identify them early and refer them. Some kids, they go to clinics, their weight are being measured every day, and it's also plotted on the book, but no action is taken. Because sometimes we looking at those, we assume probably those who are weighing these kids, some of them, they don't really know how to interpret that. So we hope if those who are working with this book, they are here and they're able to know now, from now, you don't just weigh and stop it there. You should weigh the chart and plot and interpret and refer accordingly. So now we'll come back to the malnutrition. Classification of malnutrition. We spoke about acute and chronic. When do we say it's this acute malnutrition? Acute is sort of recent onset, usually some problem that's happening in less than 3 months. So usually it will be due to some acute illness. And this one, they're usually the high risk of mortality. And when you look at their weight for age, if you look at the growth chart, it's declined rapidly. Their height is preserved. I mentioned that if the problem is a acute problem, their height is not affected. So, and they will be wasting, they look wasted. So this one, with a good intervention, good management, the recovery is good after nutritional rehabilitation. This one is reversible with a good intervention. So what about the chronic one? The chronic is coming from the persistent problem, which this chronic one, it have a potential of infecting the intellectual development of these kids. So their weight for age is low and their height is severely affected. When you plot, you see the height is very low. It tells you how chronic the child is. And this one, they are also very stunted. And if feeding for this one is also less effective. So they are unlikely to also to reverse the problem. And also we can also look at the measuring how severe, looking at the moderate and the severe, moderate and the severe, uncomplicated and complicated. When we look at acute malnutrition, we can also classify them as, for example, moderate and complicated malnutrition. So with this one, their weight is below -3 standard deviation, between -2 and -3 standard deviation. And this one, they do not have an edema. When you measure their upper arm circumference, is between 11 and 12.5 centimeters. We remember we said the mid upper arm circumference, the normal one is more than 12.5. So this one is less than 12.5 centimeters. This one who are uncomplicated, they still have a good appetite. They may look where they are also alert. So this category, you may treat them as an outpatient. They might just get a good nutritional counseling and give supplements, diet advice. They may be treated as an outpatient. But those who are also severe and complicated, some of them, if in the presence of edema, when they have edema, now I can say, for me, teach you, when you see child with a malnourished, with the edema, I will manage that child as a complicated one. So those one with edema, you should definitely refer them to the hospital. You don't manage them as an outpatient, especially with our community, because our community needs lots of monitoring. Also looking at the level of education and our understanding. So I'll definitely put those under this category of complicated. So complicated malnutrition, their weight is also can be less than -3 standard deviation. They can have a bilateral pitting edema. Their mid upper arm circumference will be less than 11. They also may have loss of appetite, they will have a present with pneumonia, with a fever, dehydration, or severe anemia. Some will present to you unconscious. So those are the complicated one. They also would definitely require inpatient care. So this is also another form of classification, but it's also telling the same thing as the previous slide. In the olden way, we talk about marasmus, which is same as a wasting, talk about kwashiorkor when there's a presence of edema, or marasmic kwashiorkor, where they present both wasting and edema. Now, all those, we no longer have to separate between marasmus, kwashiorkor, and marasmus. They are all under one umbrella of acute, severe acute malnutrition, because their management and the care is the same, whether it's a sign of kwashiorkor, sign of marasmus, they are managed the same. So now we no longer use that term of kwashiorkor, you call them, all of them, as severe acute malnutrition. These slides also give you the same message, so I won't really waste time on this one. So what are the causes of malnutrition? The causes of malnutrition, they are multifactorial. The causes are multifactorial. There are lots of things that can contribute to malnutrition. I'll take you through from these slides, because malnutrition, there are so many factors that contribute. It can be the problem in our government. Imagine the country which there are war, which there less supply of food. The kids are likely to suffer malnutrition. When look at this, we're looking at underlying causes. When look at the intermediate causes, would be the problem of inadequate environment or health system. If you're in a place with a poor health system, I mean, those kids will be sick, they will not be well managed, which with that sickness, and they will be unable to eat proper, and they are likely to become malnourished. And some end up dying. In the presence of poor water supply, getting a dirty water with all germs, the kids will be sick. They will have a severe chronic diarrhea, which can contribute to a malnutrition. Also, we have the inadequate caring from mothers and young children. So that alone also, especially the mother, they are also less education levels, or they are not educated enough on how to care for children. Or this one can also indirectly contribute to the children malnutrition. The household food insecurity, we mean there'll be insufficient food intake, and that will contribute to malnutrition. So there are lots of factors which can contribute to a malnutrition. So the issue there can be that maybe there's not enough food supply for a growing body. So there's more demand than what the food is available. So these kids, the kids who are not getting enough breast milk, not getting enough food at home, or they're getting too few meals, or they may be getting too many meals, but getting a poor quality of meals with low energy and nutrients, or diluted porridge. So this also is going to contribute to a malnutrition, or poor supervision of eating by adults, caregiver. Children are left alone to finish food on their own. You put a food there, we expect the child to eat. The child may not eat, or they may eat one spoon and run and go sit in front of the TV. So, and we assume the child is finished food, or with some other kids will just finish the food and take the same food that the child put on the child, and all the time you think the child is finished food, and the child didn't finish food. So the children need to be supervised when they are eating. There should be a routine. They should sit, prefer not to sit in front of the TV. TV should be switched off and let them sit down and finish food. And then after eating that, they can go and watch TV. It can be due to some illnesses which may increase the demand. The illnesses can be from some infection, in the chronic diarrhea, the pneumonia, TB and HIV in a country like ours, which is still a problem. So all these diseases can contribute to a malnutrition. That's why in South Africa, if you're a child with malnutrition, you make sure you have excluded TB and then HIV. And what are the changes that may happen? Changes that may happen in these children with malnutrition. So I just want to take you through some physiology, but we won't go detail, just go with some summary. So when in the presence of malnutrition, the body do have some that we call reductive adaptation. When intake is insufficient, that's in the presence of malnutrition, when there's intake insufficient, the body find a way to conserve some energy. How does it conserve energy for this child? By reducing physical activity and growth. If you have seen children with a malnutrition, they all look very weak, no energy, they look miserable, because of that energy that the body is trying to conserve, because more activity would even use even the little energy that the reserve that they have. So the body reduces physical activity and growth. And also there's reducing of basal metabolism by slowing down protein turnover, reducing functional reserve of organ, and also reducing inflammatory and immune response. By reducing this immune response, which means what? Means these kids are also prone to infections, because the body have reduced those inflammatory and immune response. And what are the consequences of the malnutrition? The consequences starting from the liver will be less able to make glucose. When the liver can able to make glucose, those gluconeogenesis, they are at risk of hypoglycemia and also risk of hypothermia, which is one of the complications that will kill these children with malnutrition. Also, the body is unable to make albumin, transferrin, and other transport protein, and the kidneys livers unable to excrete excess dietary protein and toxin. And what about the kidney? They're also less able to excrete fluids and the sodium, also putting them at risk of fluid overload. Hence, you see them a lot with lot of edema, and their heart is also weak with a decreased cardiac output, and they are at a risk of heart failure. The reason why we say we don't use fluids in these children with malnutrition, because they are likely to go into cardiac failure because they will reduce cardiac output. And also the guards have a less gastric acid, less enzyme, less motility with the damaged mucosa. So which limited digestion and absorption, which they are also prone for the chronic diarrhea because of this. And also they have some sodium leaks into the cell and potassium leaks out of the cell. So they also have some electrolyte imbalance and food retention, which also can go to heart failure. They lose muscle bulk because they are losing lots of nitrate, potassium, magnesium, zinc, calcium, copper. So they're able to also lose some muscle. So these are some of the consequences that will happen in those children with malnutrition, and they will develop complications due to the effect of what we just spoke about. What are the complications which put them at risk of dying? The main risk is hypoglycemia. If you have them, they need to be closely monitored for hypoglycemia. They need to be kept very warm in the warm room. Winter is not a good time for the malnutrition. Most of them will die because of hypothermia. So if we have them, they need to be in the very warm room. The hospital, if they have a heater, put a heat on them. You must put something to make sure they are well warm. They are not stay in their wet with the wet clothes, because that what will kill them. It also is risk of fluid overload and cardiac failure, and also we spoke about the risk of infection. So those complications without correct intervention, the common cause of death of this severe acute malnutrition, some of them were already mentioned. So they die because of the infections. They die because of heart failure, which basically that they can have because of fluid overload, to go cardiac failure. They die because of hypoglycemia, and they also die because of hypothermia. They die because of hypovolemic shock. And talking about hypovolemic shock, It's also not easy to quantify the level of hydration in this one because of the edema. You may find it difficult to judge accurately the the level of hypovolemia. So this is what kills these guys. And to prevent them from dying, so we have to do some intervention that I will talk about on how to do it. So this I'm just showing some child with some severe wasting. You can see, yes, you can see the ribs. You can see there's no subcutaneous tissue, just the bones covered with the skin. So this is an example of those one with severe acute malnutrition and the organ that what we used to call marasmus. You can look at the back, that's what they call the peggy beds. Don't know the buttocks of this old magogo, wasted. They used to look like that. This is how this child look. But there's no muscle, there's no tissue there. It's just the skin covering the bones. So these are those who have a severe wasting, severe acute malnutrition, and this one can see with edema that we used to call edema. This child with in anasarca with edema with the legs, look at the hands, also in the face. So, and others also with some edema with the skin sores. So these are how some of the children with severe acute malnutrition will look. And how do we look for the danger signs for these children with acute malnutrition? What are the danger signs? So the danger sign of acute malnutrition, they look lethargy, hypoglycemia. We spoke a lot about hypoglycemia, the shock, the presence of jaundice, the refusing to eat or not eating anything, the dehydration, the skin, weeping skin lesions, those skin peeling that I showed you in the other slide. They present with some respiratory distress, hypothermia, some present with convulsions, and the presence of bleeding and vomiting, everything. These are danger signs. So in present with any of these signs, it indicates the need for intensive inpatient management. So if they present to you with any of these signs, you should immediately refer them to the hospital for acute management. So how to manage them? We talk about initial management and the follow-up management. Initially, when in managing, the principle of managing these children with malnutrition is as an inpatient, we divide it into two phases. We divide into the initial stabilizing phase, which usually in the first week for acute malnutrition, and the rehabilitation phase. So the initial phase lasts approximately 1 week, and this involves intensive monitoring and treatment. We speak about that one in the next slide. A rehabilitation phase is take longer. It can still continue even after this child is being discharged to home. So in the stabilizing phase, here we'll be talking about the feeding. How do we going to feed this child? Preventing and treating hypoglycemia. We spoke about this, what we're gonna kill this child if it's not prevented and treated. Preventing and treating hypothermia. If not preventing and treating hypothermia, that's what gonna kill the child. Treating infection, giving a mineral, vitamin, and trace elements, and preventing and treating dehydration. In the stabilizing phase, that's where we'll be focusing at. So rehabilitation is all about continued feeding, the catch-up growth, and management of chronic infections like TB, HIV, and other infestation, and then continue administration of mineral and vitamin, and then talk about the play and love and stimulation and preparing for discharge. So the rehabilitation phase, it involves this one. Sorry. So when we go into the treatment, we have to know that what the 10-step approach in the management of severe acute malnutrition, which will be addressing that acute phase and then rehabilitation phase. Some of you may have seen these slides, which talk about the 10 steps approach in the management of severe acute malnutrition. Some they will not call it steps, they'll say about 10 prongs of management, because The steps doesn't mean for step one, hypoglycemia, hypothermia, dehydration, electrolyte like that. All these are done concurrently, which some they still calling them steps may not be correct, maybe 10 prongs, but all these are done simultaneously. So the first few days with mission will be dealing with the make sure that they are treated, hypothermia, but this one is the stage where they are, if not well managed, we are likely to lose these babies, especially in the first week. Make sure the electrolytes are corrected. Infection is treated from the start. Of note, remember, we don't give, if when giving macronutrients, you do not give iron in an acute phase. Don't give iron because remember we say that the body, that the liver is also not utilizing, making the other electrolytes, then also not producing the transferring. So giving that iron, the body won't be able to utilize it because there's no transferring in the body. And which means if not that iron not utilized, that iron end up becoming the source of infection. The germs, the bacteria will be feeding on that iron. So you do not give until the child is well. That's when you can start adding iron, usually after a second week. And we spoke about catch-up growth stimulation. So I'll take you briefly on each one of them on how gonna manage. In the first step, when we talk about preventing and treating hypoglycemia, you have to monitor glucose. You must monitor it at first, at least 3 hourly at first. And then if the glucose is less than 3 millimole, you must feed this child immediately and ensure that every feed is given day and night. These kids, they should be fed in the morning, during the day and at night. Those who can't drink, who don't have appetite, you have to put the feeding tube to feed them by tube, so that even now because at first there will be no appetite, they may not have energy to eat. So we'll feed them by tube every day and night. You can feed them every 2 hourly or 3 hours, depending on the severity. So for the asymptomatic, those who have asymptomatic hypoglycemia, you can even give them the F75 formula. And you can give them the oral 10% dextrose, and also check. And after they check glucose after 30 minutes, make sure you maintain that glucose above 3, and you continue feeding. For those who are symptomatic, you must give them the IV dextrose, 10% dextrose. So we have neolites, you can use the neolites. If you don't have in a place where you are, you only have a 50% dextrose, you divide that into 4. Like for example, we can take 25 mils, if you have 25 mils, 50%, you mix with the 75 mils of sterile water. That will also give you 10% dextrose. So this one you must really manage correctly. In preventing, treating hypothermia, you must keep this child warm at all times. Ensure that the child's body, the head is covered at all times. Avoid the draft and change wet nappies and clothing, because that's where they can acquire cold. Avoid exposure, especially cold bathing, and also feed immediately and 2 to 3 hourly. And allow the child to sleep with the mother and caregiver all the time. And then for dehydration, we mentioned there, avoid fluids except in the event of a shock. We mentioned that they have a problem with their heart, they have a poor cardiac output, so we always try to avoid fluids. And they must correct the electrolytes, correct hypokalemia, correct hypomagnesemia, hypophosphatemia, and hyponatremia. You can see this after you've done your electrolytes levels. If they are low, make sure you correct them. Treat the infection, treating them. You treat them with a high broad spectrum antibiotics. Depending where you are, you can start in the ampicillin and gentamicin. And also make sure you give them the intestinal infestation, the mebendazole and the mebendazole. For those between 1 and 2 years, can give 100 milligram BD. for 3 days for over that, other than 2 years, can give 500 milligrams as a single dose. So infection should be treated correctly. And also giving macronutrients like vitamin A, multivitamin, folic acid, and zinc. And as I said earlier on, you must give iron once the child is gaining weight and the edema also is subsided. You have treated the infection fully. And feeding, when the acute phase, we start feeding them with the F75, which, as I said, that the feed must be given 8 hourly. I know currently there are some ready-made F75 which they come prepared, so you don't need to prepare. So if in this way they don't have the ready-made, these are the formula on how the F75 can be made. The mixing there is if you're using the fresh milk, 300 ml, adding a sugar, 100 grams, vegetable oil, and a combined mineral and vitamin complex and water, that will make up to 1,000 ml, 1 liter. So mixing those, our dietitian should know better even how to mix. They can be helpful in advising the hospital, the clinics on how to prepare this. Some can even teach the same patient to how to prepare this kind of food at home. So the F75 is, we call it F75 because all this mixture will give you 75 kilocalories per 100 mils. That's where the name 75 comes from. So after that shelf phase, then you move up to F100. And then assist them to develop the gain, so can have a good appetite. So this is how to prepare the F100. I won't go detail on this one, but our dietitian, most centers have dietitian, which can also be helpful in handling this. In the event where you don't have a ready-made, if those who have a ready-made, you can just use it. You just need to warm and give the baby. You don't really need to do the mixing for those who have the ready-made. So for catch-up growth, that's when we'll be giving that F75 use for catch-up growth. And after your feeding, when they are in the hospital, they are not only there for feeding, they must also go do some stimulation. They need them, if we do this carefully, we also need the mother there to assist you to participate in this stimulation, get things to stimulate these kids to be able to be at like other kids the way that the other kids. You also need some occupational therapy. They're also very good in assisting in doing this sensory stimulation. So, and they get, as I said, encourage the mother to be involved. So this will be done all the time, almost every day when they are in the hospital until they are ready to go home. And the other thing is also you have to prepare for their discharge. You have treated all infection, you have fed them, they are gaining weight. Now you must also prepare them for discharge. How to prepare them for discharge? You also do nutritional education so that when they go home, they don't come back with the same problem. They've learned how to feed the child, what kind of food to give to the baby, the kind of fruits, the milk. So they have to be taught on how frequent they should feed their babies, how to supervise the feeding. So it needs to be done as part of the preparing them for discharge. Make sure that they're being immunized, they've received all the vaccine. If they missed, there should be a plan for doing the catch-up vaccination. And then we have assessed that the child will be fine at home. The preparation is done, is ready at home, and then make sure there's food at home. Then you have to involve the social worker to help you with doing that such assessment. For those who don't have a grant, they must get assistance to get grant. For those who don't have the issue, they don't have a document like ID. That's when you involve social workers so they can facilitate that they get the ID document and then able to apply for the grant, and they can have food to buy for this baby, for this child. And it should be sure that they should be able to do a follow-up after you have discharged them. What are the criteria for discharge? This one for children 6 months and 5 years. The criteria, if the weight for height have increased, it is up to the -2 standard deviation. If they go up to that, they are ready for discharge. If you are using the mid-upper arm circumference, it's now more than 12.5, and there's no edema for it is 1 week to 2 weeks. And the infection have been treated, you have excluded the TB and the HIV. If they are found they have TB and HIV, they are put on treatment for those. And the full immunization program have been started. And assessing on the mother and that the mother is able and is willing to look after the child after they go out of the hospital. And they know how to prepare food, appropriate food, and feed the child. They know how to give home treatment, for example, for things like a diarrhea, how to treat fever, how to treat for some acute related infection, and how to seek medical attention. So they need the mother to be taught, and on the health worker, and that the health worker are able to follow up on this child and provide support to the mother. So if we have met this, then this child is ready for a discharge. So lastly, as we finish, I hope so far we have learned something. So as a take-home message, just have to remember that malnutrition remains a global health concern and contributes significantly to a childhood mortality. You have to know how to measure the weight and the height accurately. We have shown you with those gross charts on how to interpret. It's time for you just to practice and how to interpret them so that when they come to you, you should be able to plot them correctly. And also, let's get to the habit of looking at on those books. We have learned from our patients. They hardly bring this book to the doctor's rooms. They only take those books when they go for vaccines. They only believe that book's only meant for a vaccination. So it's not that every time they go to any health professional, they should go with that book. When it corrects them when they go visit, they must put that book in the child luggage. So you must know how to interpret those charts correctly using the Z-score charts. The Z-score chart, the one that is in the road to health booklets. And it's important to differentiate between acute and chronic malnutrition, and as the management and chronic and mortality for these two conditions differ. And remember how to use the 10-step approach in the management of severe acute malnutrition. If you have the road in the ED essential drug list, so for children, pediatrics, it does have this done in there nicely. So just look at that, it will help you on how to go about. And then also, you must also adhere to the programmatic approaches for diagnosis and the management to ensure the lower mortality rates and the better outcome. So we hope from there you'll be able to save these vulnerable children with malnutrition, and we can, if we do well, we can also be able to prevent them to reaching this stage. I think, Dr. Mawela, I think my part, I've covered my part. So that's in summary just what malnutrition is all about. I know there's a lot about malnutrition, but I thought what we covered to be able to give a highlight and on how to deal with the children with malnutrition. Thank you. Thank you, Dr. Mawela. You are on the mute.
Oh, thank you for that. Yeah, so thank you very much for your presentation. You know, just to maybe manage the bandwidth, I'm going to stop the sharing of the slides so that we can engage with some questions. Colleagues, I'm also hoping that we have one or two, one dietitian, one occupational therapist. It would be nice just to get your comments, you know, about your role in all this and how we can really work together to help these kids. So Dr. Shibangu, as you can see, Dr. Shibangu, from the chart, everyone is really giving you, you know, positive feedback, because I think you have covered this topic, you know, in detail, especially around the importance of the correct assessment and ensuring that we document the weight and the height, and we use the Z charts, and we continue to check the road to health, you know, booklets, so that we can literally prevent and pick up kids who might be in trouble and act, you know, as needed. Before I check if we have hands from any dietitian or occupational therapist, maybe let's go through some of the questions that were raised earlier. Someone is saying, why is the MOAC not done under 6 months? Is there a specific reason for that? You know, and is asking if is SEM diagnosable for children less than 6 months? What is your take on that? Thanks.
Okay, so yeah, we don't use MOAC in the children under six months. Reason for that, those children, they usually have a lot of subnet tissues, so it's also including the way of feeding them, also just on the breast milk. And for them, we found that the MOAC is not really reliable in them, and some of them they may even have a less than 12.5 centimeter of MOAC. You incorrectly classify them as a malnutrition. Only find that they are not malnourished. Just it's normal for their age. So it's not really advisable to use MOAC. I think the second question, what is saying?
No. I think you have sort of covered. He was actually saying, can we diagnose SEM in the under 6 months kids?
Yeah, they can have a severe acute malnutrition. We can still diagnose them. There are those neonates when they are discharged them, they are not breastfed, they are just put on the wrong diet just from the start. They can develop severe acute malnutrition even before is 6 months. We can still diagnose that.
Superb. And then the other thing is for special kids, like kids who have cerebral palsy, you know, as still usable for those kinds of kids? Are they still applicable?
Yes, they are. Yeah, just to note that there are also some special charts that are meant for those children with severe malnutrition. Also, the chart for those children with Down syndrome and for the premature babies. There are other charts that we use that are work specifically for those children with such conditions. So, but even this one is roughly still work almost the same, still work almost similar. The difference with the ARB for those one with the premature babies, because most of them, they will usually catch up their normal weight. We have seen most of them after 6 months or around 6 months, that's when they catch up. They are doing their catch up. So with those one, you may incorrectly diagnose them malnutrition. So those one just have to look for the relevant charts which we didn't use there that are applicable for the children with we are born premature.
Okay, so even for premature kids, there are special charts that can be used, right? Not necessarily.
Yes. Yeah, special charts. Also those with Down syndrome, there are also special charts that can be used.
Okay, I think that is well taken. I see Ajil Shabalala. Ajil Shabalala, you may unmute. Are you able to unmute? I'm hoping you are a dietitian or OT. Ajil, yes. Hi, Ajil. Okay, Ajil muted herself. Mara Malaza Glenda, I'm going to try and give you the right to talk. Mara Malaza, are you able to unmute?
Yes, thanks, doctor.
Yes, ma'am.
Hello?
Yes, we can hear you loud and clear.
Yes.
You
Okay, thank you. Yes, Maramalaza is a dietitian at Dinswala Hospital, a public hospital.
Great, you are welcome.
Yes, thanks for such a wonderful presentation. You know, since COVID, we've been seeing a lot of under 6 months malnutrition cases in my hospital. Reason being that we were failing doing growth monitoring because we most of our facilities, they were booking these children, and even now they book for immunization. They don't understand the importance of growth monitoring. So you will see a 2 months old baby with malnutrition. Just to respond to the question of, are we able to diagnose malnutrition for less than 6 months? This baby was even having edema in the worst scenario. So we're able to diagnose malnutrition even through edema. So, and it's sometimes very difficult for us to give, like, to treat these children who are less than 6 months, because we will encourage the mother to breastfeed while they are in hospital. So it takes time, because you will find that the mother was not breastfeeding well at home. So the milk supply is very poor. So it usually takes time. So what we are currently doing is just to make sure that we encourage and supporting breastfeeding, so that we don't see these cases, and to make sure that these babies are going for growth monitoring on a monthly basis, so that we don't get this malnutrition. And then another challenge, it's the ones that are exposed, because you will find it takes time for us to get PCR results. And when we get those results, it's already late. The malnutrition is there, the child is HIV positive. I don't know if Dr. Shibambu, you have treated a malnutrition where a child is HIV positive and you have a successful case, because usually after a week or two, we have experienced that they just go, the demise. So I'm not sure how best can we help each other in this way to save these children who are HIV exposed, who already have a positive PCR and malnutrition, and they don't survive. I don't know whether it's the HIV or it's malnutrition itself, or it's how we give the treatment. I'm not sure. I will pause there, Dr. Mawela. I just want to comment more on the growth monitoring, that it's failing us actually in this early.
No, thank you very much. Maybe Dr. Shibambu, before you respond, the last hear from Glenda. Glenda, are you able to make your comments, and then we will continue with the questions on the chat? Thanks.
Thank you, Dr. Mawela. It's Glenda, it's a dietitian.
Okay, ma'am, thanks.
Just on the slides that doctor was presenting, there was a slide with this color-coded in blue. I've seen there was Abu Koshioko, Marasmic, and everything. I just wanted to ask, in terms of the IMC guideline that we use right now in diagnosing, to say those terminologies are not really used anymore. The IMC guideline guides us to say we can diagnose in 3 ways, which is the NAM, said as normally malnourished, the MEM, moderately acute malnourished, and the SEM, which is severely acute malnutrition. So if we can just check, because if we are not going to use the same terminologies, I think probably at the end of the day, we will not be doing justice to the people we are trying to teach.
All right. I think,
Yes, the slide was in blue, Abu Kwashi, Marasmic, and what's on. I've seen them being 3 right there.
Yeah, I think I remember the slide, and I think Doc did say that this is the old way, but they are all now classified as SEM, but that would allow him to respond to both. So maybe Dr. Shibambu, if you can respond to the issue of HIV and malnutrition, and then maybe re-emphasize the old versus the new classification. Thanks.
Okay, no, thank you very much. Let me start with the second one. Yeah, this kwashiorkor and marasmans, we no longer are using those terminology in most of our booklets in our teaching. All of those, they are all severe acute malnutrition. I did say that in the olden, because some books, when you go, you can still find those. So people must understand what it means. I also give the indication that whether you say kwashiorkor or marasmans, it does not really gonna make a change on how you're gonna manage this patient, but they are all gonna be managed the same way as a severe acute malnutrition. So we all those under one umbrella of severe acute malnutrition. So in that question about the HIV malnutrition child surviving or all dying, I tend to differ. I think they do survive. And they survive if they are managed early. So most of them, they die because of the complication that we have mentioned. They die because of those, we spoke about the issue of the cardiac, they have heart failure, because what we do, what we have seen, what killed these kids is the use of fluids, because some people, because they don't understand I try to go through the physiology part there. They come to the hospital, they are bombarding these kids with the fluids like the normal child. So this one, the fluids will kill them. I know most dietitians will agree with me. They will really shout a lot when you are trying the fluids. Preferable all feeds to be given orally, just to prevent such complication. They usually die from the complication, the hypoglycemia and hypothermia, because most of them are not well monitored. They are kept in their rooms, windows open next to the window, and all kept wet. They die because of those complications other than the HIV itself. Of course, HIV, if you diagnose it there, they have to be started on treatment right away. If you have a TB, you first start with them with that on the TB at least 2 weeks before you even start on them on the ARV, just to prevent the iris. So they die due to complication, not necessarily because of the HIV. HIV does facilitate them developing malnutrition early, and the same applies with the TB.
Great stuff. Debbie, yes, maybe there. Debbie, if you'd like to make a comment, it would be nice to hear your voice. You seem to be quite an informed person as well around issues of nutrition. It would be nice to hear from you. I see there's a question by Abel Mudiva here. He says, so at an emergency level, at casualty, what is the timing of giving the F75? Should it be given as part of the initial resuscitation in casualty, or should this be done later on in the wards? Yeah.
So I think for a casualty, I don't know if we're really going to be more practical in giving the F75. Even the time you could be looking for those, it may take long to get that the pharmacy to issue those F75 or prepare it for those who don't have ready-made. So by the time prepared, this child should be in the white. And I also remember this child, they also have a poor appetite. They may not even able to drink it there. So they will need to be put, may need NG tube feeds initially until they even get their appetite back. So I would say those F75 can be started in the white. Maybe advice for the casualty, you get a child who's severe acute malnutrition, avoid running the drips, because they start there. Avoid the drips, then that's how you're gonna save these kids.
Yeah, maybe on that note, are you able to clarify what is the best approach to assess the rehydration status of these kids? Because there was a number of questions around a malnourished child in shock and in cardiac failure. So, and we know that they might present in cardiac failure not because of their in shock. So what is the actual approach to assess shock in these particular kids? Yeah.
Okay, you can check on some capillary refill time. Remember this one, their skin tagger is not the reliable way of checking the level of dehydration, because the wasted one, their skin will look like they have a decreased skin tagger anyway, and those with edema also cannot really tell if they are dehydrated or not by looking at the skin. So capillary refill time, if you to just press on the finger, check how long it takes for to become pink again. That will be reliable. More than 3 seconds of that is telling you there's a poor perfusion. The child is likely to be severely dehydrated. So that may be the easy way to look, just to capillary refill more than most of the way we do, because may not be reliable on the one with edema or wasted.
Great. There's a number of questions about albumin infusions and the use of Resomal in shock. Would you like to make comments on that?
Yeah, I would say the use of Resomal has been used, with some them be used, but it's not really a standard use. I've seen somewhere where they are using, but in most places where I practice, we're not really giving that. And there was no room of giving the albumin. Remember, we spoke about these kids, their liver is unable to synthesize those. So we don't give the albumin as just correcting that. By correct treatment, correct feeding, the albumin level is likely to go instead of transfusing them, because they won't utilize them, and that may even cause more of fluid overload for them.
Yeah. Okay, superb. And then if a child is on a F75 formula, do we also need to add additional supplements and multivitamins, or the F75 is adequate to cover that as well?
No, not adequate at all. They still need all the supplements. Okay. All those multivitamin, folic acid, zinc, magnesium sulfate, they need the supplements. So that one does not really have all those nutrients. If you have checked how to make them, they don't have most of those nutritional elements. So they still need all those supplements.
Okay, great stuff, Doc. I think we are getting it. So with respect to children, I mean, infants who are less than 6 months of age who present with severe malnutrition, F75, F100, is there a place for that, or we are relying only on breast milk?
So, yeah, we can still use, usually those who are malnourished under 6 months, they are those who are not breastfed. They are not breastfeeding. They are usually on some they're not even on any formula at home. They are just giving this tea that I was talking about. I'm from Limpopo, so we have the culture of drinking tea, rooibos tea and Mavera salt porridge. So, so the F75 stickers, they're still gonna be used for them, but you just have to be closely monitored. That's where they need pediatrician, they need a dietitian very much involved. Preferable if they are in the periphery, those are the kids that may be managed in the secondary or the tertiary level. In the secondary, they can manage them well than in the primary level, because they need a very close monitoring.
Great. Yeah, I think we have sort of, went through most of the questions that have been asked. So I must really, appreciate you, Doc, for the presentation. I think the big topic, you have managed to summarize it, but I see that there's a number of questions. Actually, there's a lot of questions about special, subspecial populations in the pediatric space, your premature babies, your CPs. children less than 6 months, to say it seems like people need a lot of clarity around whether this intervention is still relevant, for the same group of babies, this special population. So we might need to come back and maybe evaluate and look at that. Maybe let me give you a chance. Okay, maybe before we close, 2 more small questions. The approach to severe low natremia, and someone also spoke about severe malnutrition, hyperglycemia. These are unique cases that might be a bit challenging for colleagues. So maybe talk to a low sodium in the context of SEM, but also a high glucose in the context of SEM. Thanks, Doc.
Okay. So yeah, it's okay. Talking about the hyperglycemia. Hyperglycemia may not necessarily mean you are overfeeding these kids. It may also come as a stress response. When they are under stress, the body develops some mechanism to try to balance. So the hyperglycemia may be also a sign of a stress response. So, of course, even now in the presence of hyperglycemia, they still need to feed them, because you are seeing that, but in the tissues they do not have. There may be less glucose in their tissue. So you still need that. For the issue of hyponatremia. Hyponatremia, of course, hyponatremia also need to be corrected, but while we correct it very, very slowly. If you are going to give a bolus of normal saline trying to correct it, you should be pushing that child to the edge, which it is not gonna be helpful for that baby. So even that, you have to be cautiously treating it. Preferable quality care for this should be done orally without having to go through the fluids, because now we are talking about sodium, you want to give potassium. So yeah, how treat it will slowly on its own correct as you are giving the correct feeding. So let's also be cautious as we are going to give that normal saline on these kids, because it's not gonna be good, especially in those in the severe form.
Superb, Doc. So before you close, Doc, I understand that in the same household, you could have a very obese, overnourished person and have a significantly undernourished child. What is the dynamic there? I don't know if it's something you have observed. What is the dynamic really? It is at the community level.
Yeah, there are many ways. It can be one of them is really overfed or eating too much, or either the other one that look like obese is the one with the less activity, is not really having some doing any physical activity. And another thing is, I did spoke about the supervised feeding. You find that maybe you are dishing, these kids are eating together in the same plates. That guy is finishing eating more. The other one was not eating less. At the end, you may assume everyone ate. Only one of the one who looked malnourished is the one who's eating almost all the time. The other one ate even less than quarter of the feeds. So with those advice, then it is every child should have own plates, and you make sure each and every child they finish the plates. In the olden time, we used to eat as a sibling, used to eat in one plate. Yeah. So it's a survival of the fittest then. So if that's something might be happening currently in some of our families. And also must say that those obese child, as I said, is also maybe also malnourished, because obesity is a malnutrition on its own. It's a overnutrition. The other one is a undernutrition, but it's also a malnutrition, which may also need to be attended before, because the complication for it may also be severe.
Yes. Okay, Doc. Yeah, so your closing remarks, that's it for today. We are just 1 minute before past, so let's then sum it up. Yeah.
Okay, yeah, no, yeah, I want to say that thanks once more for inviting me. It was really good session, attendance, participation. It was great, and I hope we have learned something. I'm not an expert. I'm also learning. So with some of the question coming, I'm also learning from those, because some of them question will also send me to go and check some more answers that we are unable to provide here. So it also is a learning in the process. And I hope we have learned, we'll be able to go look at our road health booklets when our kids come to your clinics or come to your surgery, look at them and then plot, interpret, and advise accordingly, and refer those who look sick, who are undernourished. So I think from me, thanks a lot. I think that's all I have for tonight.